you can see from what's been said about me, I'm probably the least knowledgeable person in this room today, either about newborns or about genomics. So forgive me for all of that. But I do want to bring a perspective from the UK National Screening Committee so that you can see where this fits into what our thinking is. And I think the first thing to say is that newborn screening, the traditional screening, enjoys very high levels of public support. In the UK, the uptake of the blood spot screening is over 99.8%. Now, as somebody involved in adult screening, that is quite remarkable. And it's remarkable for any public health programme. And obviously, we want to preserve what is good about that, but also then to build on it. And at the moment in this country, we screen for a relatively small number of conditions in comparison with other countries. We are very much aware of that. And all of these have been recommended by the National Screening Committee. What is the Screening Committee? It is the body that advises ministers in all 4 of the UK countries, England, Scotland, Wales, Northern Ireland, on what screening should be available, both in terms of fetal, maternal, child health, and in terms of adults as well. And our recommendations go to the chief medical officers and then to ministers, but we only make recommendations. In practice, our recommendations tend to be accepted. Politicians in general, as long as they are advised that screening does more good than harm at a reasonable cost, they will approve it. And that is the mantra that we go for. I mean, there are about 20 different criteria we go for, but more good than harm at reasonable cost is the shorthand version of it. So what are we looking for? We're looking, first of all, to say, is this an important health problem? And that can be a very common condition, so we have recently recommended screening for lung cancer in adults, targeted specifically at people who are smokers or ex-smokers, or it can be a very rare condition. I'll come on to one of those that we've recently approved in just a moment. So the frequency, it's a combination of frequency and or severity. And then just say it again and again and again, we need the high quality evidence that proves that screening would do more good than harm. So, what are we currently screening for? And I put this in largely as a reminder to myself, but also to show it's a small number of conditions at the moment. These are the conditions that effectively I inherited when I became chair of the screening committee. You can read the list for yourself, but the important thing is that it is a small number at the moment, and that 6 of those are inherited metabolic diseases, or IMDs. So the question for us has been, okay, what should we do next? And you've already heard that we're just over 60 years since Robert Guthrie developed the blood spot, and that was originally for PKU, and obviously has expanded from that. So we are very pleased to have added one condition in the last year to our blood spot, that is tyrosinemia. Really interesting process. This is, again, was new to me, but what do you do? In this country, there are probably about 7 newborns a year with tyrosinemia, and a couple of them may be identifiable because they've got siblings with the condition. So we are screening for an extremely small number of patients. That makes the analysis of benefit of good over harm really difficult. For these children, and again, in my clinical practice, I had never seen one of these children, and I don't know how many people in the room have. But what we were told, okay, it can lead to learning disabilities, it can lead to liver failure. You can, of course, then potentially transplant a new liver, and if you transplant a new liver, actually you can overcome the original metabolic problem. Weighing all these things up, and there is a treatment for it, and trying to look at the cost effectiveness as well as the benefit was really tricky, but the committee came to the conclusion that we certainly should recommend this, and that recommendation has been accepted. We are now in the process of looking at severe combined immunodeficiency and assessing that, even more complex in many ways because of some of the actual technology issues about screening for it. And we are thinking hard and assessing the evidence for spinal muscular atrophy. But you can see that is a small number of conditions and a lot of work going into those small number of conditions. But we are now really at the point of saying, what about the new genetics, whole genome sequencing, and where does that fit in? And we are really delighted that a large-scale study, and there are people in this room who know vastly more than I do about that, the generation study in this country is being developed and will involve approximately 100,000 newborns. So, but the care that is going into designing that study is really, really important. And it's really important to us on the screening committee that we are involved in that process. We're not going to be running the study at all. That's not our job. But we do want to make sure that at the end of the process, we get the information that we as a committee will need to make a recommendation, whatever that may be. So, and this is something that in recent months and years, the National Screening Committee has been doing much more of, which is to liaise with researchers at an early stage to say, these are the things we will need to know if we are going to make recommendations to ministers and therefore to the country. So, what are the opportunities? And again, a lot of you will know a great deal more about this than I do. It's already genomics being used as a second-tier test in screening. So if newborn screening identifies a baby as being a carrier of the CF gene, recommended parents find out if they're carriers, and genomics comes in there. But it's got a huge potential. What you've already heard, early detection of many more rare, treatable, actionable, we can talk about the language, in babies before symptoms develop. And that has potential for better outcomes and quality of life, both for babies and for their families. Hopefully, it can actually prevent the onset of disease, and you've already heard about the case study, and I love the pack of pills. Like that, I must buy some of those myself so that I can use that too. But even if we don't prevent the onset of disease, getting a timely and accurate diagnosis, and I absolutely take the point about a genetic variant is not necessarily a diagnosis in itself, but what subsequent tests do we need to undertake to confirm a diagnosis? And then, really importantly, we need to be able to make sure that there is access to care and treatment once we have discovered whatever variant that may be. And the potential then also to help proactively in decision-making so that we can improve health for the future and the health of the family as a whole. So there are lots of opportunities about which we are genuinely excited. But now I'm going to come on to challenges, and I think there are 3 slides on challenges. So we only had 1 on opportunities, but 3 on challenges. But I think we all know this as well. We've got to balance all the potential that we've just been hearing about with the need to protect what we've already got, the blood spot legacy, and make sure that as we go forward, we do have the necessary scrutiny and derive the necessary high-quality evidence. So we're thinking well in advance of getting any results from a generation study and indeed other studies as well. How are we going to go about assessing multiple conditions in screening? Up till now, we've only ever assessed a single condition at a time. By the way, we are doing this in adults as well. Many of you will be familiar with the fact that there are multi-cancer early detection tools that are being trialed at the moment. And we're going through the same thought process as to how are we going to actually assess whether a test that may be better for one of the adult cancers than the others. How are we going to assess that? And we've set up a separate group within the screening committee, a research and methodology group, that is really helping us to look at this, and is also going to be working closely with researchers to make sure, again, that we get the answers we need in due course when the study comes to fruition. Do we need to clear the same very high evidential bar for every condition that we test for before we can recommend its use? If it's clear-cut that it works for a number of different conditions, do we make assumptions about others? That is very much still up for further thought. And then there is the synergy between the genomic test itself and metabolite-based and metabolomic approaches. So, you know, it's not just one approach at a time. So that was the first lot of challenges. Again, we're already hearing this. How do we define what an actionable condition is? And actionable versus treatable, etc. And I think we also need to recognize that with any screening, there is the potential to cause harm as well as benefit. And so if we look for multiple conditions, are we going to multiply the potential harms? Overdiagnosis, overtreatment, false positives, false negatives. We know those are true in all screening, so that they will be true here as well, or we assume that they will be here as well. And what about discovering mutations that might only result in disease later in life or not at all? What do we do about those? And I know that a lot of thought has been given to that already. What about genetic changes of unknown importance or significance? What about the lengthy follow-up that might be needed, the potential for psychological harm that might go with that? What would we need to know about what the public thinks? And you've already heard people say that how important this is. And again, just to say, I think it is so important that the studies that are going ahead on this are engaging a lot with the public to tell what is acceptable. And then what do we mean by informed consent? You know, it's all very well coming from my world of adult screening. If you're giving informed consent for breast screening or for colorectal cancer screening, you can explain what the condition is there and what the test would be. But with whole genome sequencing, are we really going to explain several hundred different conditions to every person, every parent as they go through screening? How do we do that? And I think we just need to learn as we go along for that. So I think I'm coming to my final page of challenges, you'll be pleased to hear, because I don't want this to come across as negative. I want it to come across as we all need to think these through. There is, of course, the potential that if there was loss of confidence in whole genome sequencing, that might impact on our already, what we believe is very successful program of the blood spot. And then the ethical issues. I've already mentioned informed consent, but particularly difficult when we come to things of uncertain importance. What do we mean by screening should directly benefit the child? Does finding something out that actually may help save the parent's life, is that a direct benefit to the child? It's not for me to answer that, by the way. It is, that's a societal question, but it's one that I think we need to take into account. And obviously there's going to be masses and masses of personal data. We need to make sure we handle that appropriately and with necessary safeguards. And the inequalities issues, inequalities both in data collection, but inequalities in terms of access to treatments. We really have got to make sure that if we do find things, that the access to treatment will be the same for all newborns across the country. So I can now say, how are we going to meet these challenges? Well, we are working very closely with Genomics England and to look at all of these things. In addition to that, we are commissioning via the National Institute for Health Research Evidence Synthesis Programme, a review of benefits and harms of whole genome sequencing worldwide. So what is out there for us to learn, because we don't just want to learn from this country. And I think this is where ICoNS really plays a part. We want to know what everybody else is doing so that we are alert to that. And we do think that international collaborations like this conference are really essential for gathering evidence, for making good policy, because each of the conditions is rare in itself and numbers are therefore so small. Monitoring long-term outcomes, I think, is really going to be important, and that is something that I think we then need to persuade governments to invest in. This will be over years and even decades to see really what the impact of screening has been in the long term. And I've said it before, I'll say it again, parents, patients, public must be involved in planning and design of work so that we can incorporate whole genome sequencing into our current newborn blood spot screening. And just finally, how are we going to meet this? Clear information, very difficult when we don't have all the information that we might want. We need to make sure that when we do find positive cases, how are we going to inform parents and clinicians of that? Because these may be widespread across the country. We will need continued work to evaluate the penetrance of conditions. And is screening really being effective? Stress again, we need to look downstream as well as at the screening itself. What about the diagnostic and care pathways? We need consistent data definitions, data collection, reporting, and like any other screening program, we will need quality assurance processes so that we can really see, is the screening program delivering to the high standards that we have set for it in the first place? So just to conclude, to say I am very excited about this. I may have highlighted an awful number of challenges and problems. These are not new. It's not us that's raising these. You know these as well as we do, but we will have to make the final decisions, and so making sure that these are being addressed during the course of research is hugely important, and we are very, very delighted that they are being so done. So thank you all very much indeed.
I'm Kostov, originally from England, but now in Sydney for the last 15 years. Tandem mass spectrometry in Australia started in 1998, and in Germany soon after, around then. Looking at a spectrum of disorders without the evidence base that you're hinting that you require, the investigation itself provides the evidence. And many lives have been saved that are still not being screened for in this country using tandem mass spectrometry. The multiplex assessment needs to be right at the beginning of the process, in my opinion.
I am the first to acknowledge that at the moment we only screen for a small number of conditions in this country. We are reconsidering that, so yes, we're looking at whole genome sequencing, but we're not confined to that, and it's a very active debate, and as chair of the screening committee, that body brings together a whole range of different experts, and they will then bring advice to the main committee, and I think there is a strong case that we don't screen for enough conditions at the moment, and do we? What is the opportunity with tandem mass spectrometry? I absolutely agree with that, and it's a live debate, is all I can say.
Hi, Michelle Levine. Thank you for a really interesting overview and introduction. I'm up here, Mike. Up in the gallery.
I can't see a thing, but anyway, ask your question anyway.
Thank you. So I noted and was really happy to see that there's active consideration given to two diseases, SCID and SMA. And I'm also aware, and I think lots of people in this room are aware, that many other countries are already screening newborns for those two diseases. And I do understand that there's the need for the UK to evaluate UK-specific evidence and so forth, but how do you think about the balance of wanting to acquire more information, do more analysis, versus the babies that are being born every year that if they were born in the US or many European countries would receive a positive screen, and while in the UK, while we do more analysis, I guess they unfortunately don't. So I just want to, I guess the question, to phrase it differently, is how do you balance out the urgency to take action in a world where genetic medicine is improving and opportunities to treat or take action are improving quite quickly, versus the need to do the right analysis to make sure that the benefit outweighs the harm?
Another very live question in this country, but I think our approach to that is what we are talking about now as in-service evaluations, and which is not the same as research. It is saying, let us get started, but let us make sure that we actually collect the information that we would need on a large sample within the country, so that we learn, and then if that works, then we spread it. So that is an approach that we are now advocating. Again, we're advocating it both in adult screening and in newborn screening. So that, I think, is the likely way forward, and with SMA.
Thank you very much. Oh, sorry. It's Enzo Ranieri from Sydney in Australia. May I ask your view on the identification of late onset disease and how you think that might need to be approached, how you're going to deliver that information to parents about late onset disease? And you could probably drag your analogy for the BRCA1 and BRCA2 and so forth. So what is your personal view on that?
I think it's quite important that it's not me that has a personal view, that it is the committee that has a view, and the committee seeks the views of a wide range of people in society. So my own personal view on that is perhaps not what matters. What matters is, can we make sure we reach consensus? And there will be very different views. I mean, I mentioned the example of is keeping the direct benefit to the child is keeping the parents alive, but part of that, well, you could say BRCA1 or 2 could come into that. If somebody then finds out that they could be developing breast or other cancers, that might be a very direct benefit. Equally, you could say the same with familial hypercholesterolemia, and I think these are live questions, and what I am really keen is that we do think about them, get the consensus of them on them. I have an open mind. I think I'll go as far as to say I've got an open mind. Thank you. That's very generous of you.
Thank you so much. Thank you, sir. Professor Michael Richards.